Today I will be discussing does disease progression potentiate the effects of polytobacco use, a characterization of intention to quit among newly diagnosed HIV positive smokers. This work is with collaboration with Damon Vadrine, the Associate Director of Oklahoma Tobacco Research Center. I completed this analysis this past summer after he inquired for my involvement. And so let's begin. With the rise of antivirals, we see that the fatality rate among people living with HIV is significantly declined. We still see that this population displays disproportionate health vulnerabilities. In fact, smoking-related deaths among the subset are 2 to 3 times higher than the general population. This is revealed in the work of Helleberg. Helleberg looked at a population-based study which examined electronic health records and causes of death over a 5-year period from 2005 to about 2010. Again, this was done in Denmark. The figure to my left suggests a synergistic relationship between HIV and smoking, in that you can see the figure, it's stratified by both smoking and HIV. The lower trajectory here is the HIV positive smoker group, and you can see that there's a rapid decline or an acceleration in age of death. So on this x-axis we have age of death, and then we have the proportion of the Denmark population here on the y. Another subset that's not noted in this study is the polytobacco subset. And so polytobacco users are individuals who are defined by the multiple use of tobacco products. So individuals who, yes, they smoke cigarettes, but they also use electronic cigarettes. And this is defined by increased nicotine dependence and increased prevalence for smoking-related cancers and therefore deaths. And so while this population is highly motivated to quit smoking, we know that this is true, they have strikingly low smoking cessation rates, specifically compared to the general population. And so this study aims to describe, over time, intention to quit among various tobacco product users. And so just to define the study, or our sample, pardon me, it's predominantly black males with low level of education, and this just highlights the disparity that's present within this subset. The age mean was around 38.7. This took place at the Thomas Health Street Center, and so this population is representative more so of Houston, Texas at MD Anderson. Here we have the tobacco prevalence, so you can see it's predominantly cigar users. And these cigar users, it's important that you understand this because I just referred to the large African-American population within this analysis, and so these are the most prevalent, this is their most prevalent product of use. For the sample, it included individuals who were smokers, so individuals who had smoked within the past 30 days, as well as had smoked 100 cigarettes throughout their lifespan. All individuals and participants were over the age of 18 and then were deemed eligible by their physician to participate in the study. The study occurred with 5 different occasions. So we had our baseline, so the initiation of HIV care. This is when these individuals were diagnosed as HIV positive. We then have follow-ups at 3, 6, 9, and 12 months. At the 6-month occasion, this is when these individuals initiated their antiviral medication. At our baseline, it included self-interview, so self-report, and then biochemically verified measures of carbon monoxide. And carbon monoxide is a marker for the consumption of tobacco. So just keep that in mind as we look at abstinence and intention to quit. All follow-ups were then replicas of our baseline assessment. So for our measures, so we have an intention to quit, which is our outcome. This is our dependent variable. It's on a 7-point Likert scale, and it simply asks, do you plan to quit smoking? For our independent variables, we then have time from HIV diagnosis, so time from baseline. HIV disease progression, which is defined by either stable or progressive, so individuals who have a CD4 count below 200, or throughout the study had also had an emergence of an AIDS-related disease. We then have tobacco product use, which is either mono-cigarette or poly-tobacco users. So mono-cigarette, again, the individuals who only smoke cigarettes. Poly-tobacco implies that they smoke more products than that. And that is a yes-no questionnaire. We then included some covariates that are known to confound intention to quit or abstinence. This includes things like mood, so depression, negative affect. Also, we looked at, obviously, substance use, so alcohol, and then some smoking-related attitudes and outcomes as well. For our statistical analysis, we began with descriptive statistics and bivariates to identify any kind of pre-existing differences between our samples. We then stratified for our groups by both tobacco product use and disease progression. So we have individuals with stable HIV who are mono-cigarette users, individuals with stable HIV who are polytobacco users, and then the same for individuals who are with progressive HIV. So progressive HIV mono-cigarette users, progressive HIV polytobacco users. We then used linear mixed modeling to then isolate the interaction terms within this. We then stratified that and changed our reference groups to compare and really isolate the effects and where they can be attributed in our model. And so this is simply what I just stated. And then I will then go and move on to results. So we have, again, our different groupings, our subsets, which is divided, again, by disease progression and tobacco product use. We see that there aren't any kind of significant differences between our groups here. That's evident by the insignificant P's. We then see that when we look at some additional smoking-related outcomes that these individuals do have different nicotine dependence, which further strengthens my stratification. Earlier I said, and the literature has claimed, that polytobacco users do have increased nicotine dependence. Individuals with progressive HIV do have increased symptom burden, and so we saw this is true, and it just adds to the validity of our study. So here is the take-home piece. So we have our 4 trends. Again, you can see that our 4 subsets are by stable or by disease progression as well as tobacco product. So for example, our stable HIV individuals will always have the bold line, and then our tobacco product use is then delineated by the color. So our stable mono-cigarette users are the bold red line. So that would be this line here. And so we see, just as we go from baseline, we see that there is this decreased intention to quit. So it may not be a great or optimal period for individuals to have an intervention with a smoker. It's really complex. There's a lot of things going on. Perhaps they're handling this new diagnosis. So this isn't a time point where intervention should be implemented. We then move on from our 3-month point, and we start to see this rise, and it's continuing to rise, and we see this peak for our subsets within this time period. Remarkably, there after the 6-month point, we see some kind of divergence between our progressive users, which are, again, the dashed lines. So we see individuals who are progressive polytobacco users, they have this large decline, this large drop here, which is the blue dash line. And then we see that with our individuals who are stable progressive mono-cigarette users, they continue to rise. So they continue to have higher intention to quit thereafter their diagnosis. But what is really leading this interaction? What's responsible for this? We needed to then build the model and find significance for that. Here's our model. This is everything that's included after considering for what's the best fit. The covariates that are included in this are depression, negative affect, and then hazardous drinking. These were included just because theoretically and conceptually they're known to confound intention to quit or abstinence of smoking. We then have our interactions, which are denoted by the asterisk side at the bottom, and you can see that our interaction between disease progression, tobacco product use, and time was significant. And so it's really stating here, okay, so it's dependent upon all 3 of these variables. We also saw some significance with depression, and so that may be moderating intention to quit over the disease as the disease progresses. And so when I said that these individuals have this drop, right? We see that these progressive polytobacco users have this large drop. And why is that, though? Is it because of the disease and its progression, or is it because of polytobacco use? And we saw that, yes, individuals with progressive HIV, they generally actually have an upward trend from their diagnosis to a year. So their intention to quit rises over a year's period, where the opposite is actually true for individuals with progressive HIV who are polytobacco users. Perhaps there's too much. The burden, it seems, as we looked at further analysis, so I've repeated this analysis since this, looking at smoking cessation and abstinence, as well as some other covariates. And so what we see is that these individuals, they have this increased symptom burden. It's too much for them to handle, and they start to drop off. And so their quit attempts over time, especially after the 6-month point, stop. They're no longer even attempting to quit smoking. So that's really interesting. Additionally, we looked at what would be the most optimal time period for like an intervention, and we said that universally around 3 months would be the best time for this. So just to recite again, we observed a 3-way interaction between disease progression, tobacco product use, and time from HIV diagnosis. Although individuals with progressive HIV do generally increase their intention to quit over time, we saw that polytobacco users actually demonstrate the opposite, the inverse. What should be considered in the future is that individuals susceptible to HIV should be reached. So we should outreach to the LGBT and African American community to stop and to attempt to stop polytobacco use and its spread throughout these subsets. Additionally, within clinical setting, we should be screening for polytobacco use. And then lastly, future research should tailor to these findings, basing intervention upon both time, disease progression, and tobacco product use. So as of currently, I'm working with Dr. Marcotte on his India study, where I'm looking at the neurocognitive effects of tobacco use upon individuals with HIV. It's really interesting. I'm specifically interested in the inflammatory and vascular responses to tobacco use upon these subsets and how this causes impairment. I'm also interested in parsing out the effects of marijuana. So earlier I mentioned cigar use and its prevalence within this population, specifically within African Americans. So what I think is happening here when individuals are actually reporting cigar use, I think what's happening is they're reporting, they're actually using blunts. And we see this is very prevalent within polytobacco users. They combine marijuana and tobacco use at the same time. So I'm interested in seeing what effects are really happening, and does this then influence intention to quit smoking tobacco products, this use of marijuana? Lastly, I'm interested in immunologic functioning of the effects of polytobacco use upon immunologic functioning. We know that as an individual increases their nicotine dependence and they consume more nicotine, we see that there's an inverse relationship in that their immunological signs then fall. I would like to thank my mentor and my other mentors who have supported my work, and my co-authors for this study, both at MD Anderson here in UCSD and then at Oklahoma University. Lastly, I'd like to thank my funding for this project, as well as the funding that brought me here today. Thank you.
Thank you, Micah. Questions? I have a question to start off with.
Yes.
When you described polytobacco use, it's not a term I previously heard.
Okay.
And I think it included people who used electronic cigarettes plus other forms of tobacco. At least early on, electronic cigarettes were viewed as as a bridge to discontinuing smoking. They thought if they could get off regular tobacco products, they were more harmful than the electronic cigarettes. Was evidence that the group that was new to the electronic cigarettes a higher intention to quit group, or did that not seem to be an issue?
So I did consider looking at this. We don't have enough power to identify that effect within this sample. At the time that this data was collected, electronic cigarettes was not a growing market.
What was the time frame?
So around 2000 to 2005.
Okay.
Yeah, so it's a little early.
Yeah.
But in other work identified that there are different, there's a difference in the severity of the effect dependent upon the tobacco product that they use. So dependent upon if an individual is a cigar and cigarette smoker or a cigarette and electronic cigarette user, they will have varying levels of intention to quit. And I think that's what you're asking. With electronic cigarettes, it's highly debated about its position and role as a cessation product, and because it facilitates the use of other drugs.
Sure. Other questions?
How did you all define stable HIV versus progressive HIV?
If an individual is defined as having progressive HIV, if that individual dropped below 200, a CD4 count of 200, and had the emergence of an AIDS-related disease over the course of the study.
Hi, I just wanted to ask in general if you're seeing a lot of bad health effects from e-cigarettes, and people think just conceptually that they're safer, but are you seeing data that they could be the same, worse, not that much better,
Yeah, no, it's a really interesting debate that's occurring, and some of it is actually very salient to the HIV community because it's being considered, perhaps this is an alternative, perhaps we can have an electronic cigarette intervention. We do see increased inflammation from the use of electronic cigarettes, so it may not be the best idea. But specifically, just like within the general population with electronic cigarette use, there are a lot of different variables. It's a very complex model that proves for it to be deleterious. So a lot of the older models, so there's generations of electronic cigarettes. We have first, second, and third. First generation models, they don't work. You don't get enough nicotine really to be able to quit. A second generation models, they have high carcinogens within them that they emit because the voltage isn't properly manipulated for their use. Third, so the most recent, it's completely unregulated, so an individual can customize the device however they'd like, but how they are released from the market is actually reasonably safe. Does that answer your question?
Okay.
Sorry.
One final question.
I guess I have a comment and a question. And the comment is, this is wonderful that this sort of research is being applied to HIV because we see this, the notion of a sentinel health event being related to intentions to change health behaviors. So they've done research in tobacco use around cardiovascular risk. So people that have had heart attacks or some other kind of MI will have greater intentions to quit smoking. So seeing HIV kind of following the same trend of a sentinel health event being associated with intentions to quit is wonderful. And then now the question was, did you see any correlation, if it was measured, between intentions to quit and actual attempts to quit? Because that may be somewhat related to how the polytobacco users may have tried to quit, but because if they are at greater dependence, if they have physical dependence, it's more difficult, and then their intentions kind of drop.
Of course. So there's like a threshold effect where an individual will rise in the amount of times that they attempt to quit to a certain point, and then they'll cease. And that's what was replicated in this study, which I was discussing earlier. And you're head on about that. Your first comment, what I would argue is that these individuals, so what we see in a majority of disease health models, which is where you have a disease, it's diagnosed, and then you're able then to quit some kind of maladaptive behavior like smoking cigarettes, is that there's usually very high intention to quit at the diagnosis, upon the diagnosis, and that's caused by, oh, I have this illness, I have this, but we see the opposite to be true actually within this subset. So within cancer patients, they're very high to quit at baseline, but 12 months later, they're not, where the inverse is actually true among this HIV population. So it's very interesting, and I think a lot of it has to do with the low level of self-efficacy among this subset.